you for joining us this afternoon. Chuck Ingolia is going to be talking to us about the Excellence in Mental Health Act Medicaid pilot programs. Chuck is the Senior Vice President and Public Policy and Practice Improvement Director at the National Council for Behavioral Health, and we feel very privileged and honored to have him with us today for this webinar. So let's get started. Chuck, thank you for being here in Portland.
Well, Pam, thank you for the invitation. Thanks to everybody who's on the phone and for the folks that are in the room. As I was thinking about coming out to Oregon, I was trying to think about how to connect with my audience. So first, at the National Council, we represent all the community mental health programs around the state. You're all our members. We're so grateful for your membership and for the work that you do. I thought the other way maybe we could connect, and I used this slide this morning, so if the people who were here this morning forgive me. But I grew up in Michigan, and I'm a University of Michigan fan, so I've hated Ohio State since I was a very young man. So perhaps there's some synergy there, too, some things we could agree on in that regard as well.
How are you on the Seahawks?
What's that?
How are you on the Seahawks?
I'm agnostic. Agnostic. So I appreciate the opportunity to be here today to talk about a provision that was included in a piece of legislation that was passed by Congress. And that in itself, I think, is a remarkable thing, right? that the 113th Congress, the one that just ended, was one of the least productive sessions of Congress in the last 50 years in terms of the overall number of pieces of legislation that it produced. And somehow it also was, in recent memory, one of the most significant from the perspective of behavioral health, that the Congress really wanted to make an investment in improving access to mental health and addiction treatment around the country. And I want to talk a little bit about what that opportunity is, what we know about it, and there's also a lot of unanswered questions right now because we're in a rulemaking process. But I'll try to fill in what I can. It's important to hear your questions and concerns, and then to think about kind of next steps together. I think one of the reasons Congress was willing to make this investment is what we've been saying for a long time, that treatment is effective, people recover, prevention works. Lots of other people are starting to come to the same conclusion, right? That our success rates for treatment, if people can access the right treatment at the right time, the opportunity for success is very high. We also know that as we're entering into this integrated care world, and I think you guys are probably on the front ends of this, that if we don't pay attention to underlying mental health and substance use disorders as they interact with other chronic illnesses, we're not going to achieve the AAA. We're not going to make people healthier. We're not going to save our system money, and we're not going to improve individuals' experiences of care. So we know that this is important, and yet we know we've got a long way to go, right? That compared to some other chronic illnesses, we have not advanced this far in terms of reducing impact for populations. If you look historically, suicide is a flat line for the last 30 years, whereas our country has made tremendous progress in some of the most other common causes of death in this country, whether that be heart disease, diabetes, even cancers. The morbidity of those things has significantly decreased. Suicide has remained rather constant. The number one cause of people receiving disability in this country still remains behavioral health disorders, and that's a worldwide phenomenon as well. So we know that not everyone is having access to the right care at the right time of the right duration to have an impact. And also what this opportunity that I want to talk to you about is trying to address that, trying to say how can we do a better job. I'd say also what I thought was incredibly good, how do I want to say this? Because it's a bad thing, right, that the rate of opioid addiction and abuse in our country is staggering. The good news is that I see more attention from Congress to this issue in the last few years than I have, in all the time that I've been in Washington, that there's a lot of discussion right now about what we need to do to address this, both in terms of expanding treatment capacity as well as how do we focus on reducing access to opioid treatment. So I think that's the other opportunity that we have, is how do we think about leveraging the Excellence in Mental Health Act demonstration to improve access to care. And I think that's, as I think about, kind of the National Council and how we got involved in any of this activity, right, it really comes down to two things. How do we make sure that there continues to be access to care, especially for people with more serious disorders? We're huge advocates for integrated health care. We think that more screening, diagnosis, and treatment can and should happen in primary care, and yet we're also concerned about making sure that there remains a safety net for people who have more serious disorders. They're a low incidence population, but they're a highly disabled population, and we have a lot of concern about about protecting them into the future. We also want to make sure that the organizations that have historically served them have a role into the future. Now, we're not naive to think that the next 20 years are going to look exactly like the last 20 years, but like any other part of specialty medicine, there will continue to be a need for specialty behavioral health, just like there continues to be a need for endocrinologists and other specialists. That primary care can do a good job of screening to determine if you have diabetes, but some people actually need to see a specialist. Same thing with cancer, heart disease, etc. And certainly in this environment of experimentation, I think we are really concerned that there is not, that we need to make sure that there remains a viable role for specialty behavioral health. The other part that weighs a lot on us, working in Washington, interacting with Congress and with other federal agencies, is we think something very important has happened over the last several years, which is there's widespread recognition that mental health and substance use services are an essential part of healthcare. If you think about the federal parity law that was passed in 2008, the way behavioral health was treated in the Affordable Care Act, it's very clear that we're seen as an essential part of the rest of the healthcare system. And yet, we don't have any of the same kind of infrastructure on the federal level that every other kind of provider has. So I didn't include these slides, but I have a slide that says something like, what do ketchup and federally qualified health centers have in common? And the answer is they both have a definition in federal law. And if you think about any other provider type, there is a definition of what that entity is. Different kinds of hospitals, nursing homes, home care agencies, federally qualified health centers, individual practitioners. And that becomes important when we're trying to then say, how do we expand kind of services or funding for this entity, because sometimes we get asked to answer really difficult questions. How many mental health programs are there in this country, and how many people do they serve? What services do they provide? And we can't answer any of those questions. And so from a policy perspective, that's important, but it's also important from a quality improvement perspective. If you can't measure it, how can you improve it? And nationally, we have no idea what's happening in the specialty behavioral health sector, both in terms of people served, what kinds of services, et cetera. So how could we ever hope to improve care if we can't answer questions like that? So against that backdrop, a piece of legislation was introduced in the last Congress, and ultimately a scaled-back version of it was passed by Congress. Now, I think what's important about this is that I'm going to use Washington words. The legislation was bipartisan and bicameral. We had bills in both the House and Senate that had strong Republican and Democratic support. So in the Senate, The woman in blue is Senator Debbie Stabenow. She's a social worker from the state of Michigan who's on the Senate Finance Committee. She was kind of the lead Democrat on this bill. And then the guy next to her with his hand in the air is Senator Roy Blunt from Missouri, who is in Republican leadership, former whip in the House. He was working this bill just as much as she was on the floor of the Senate. And I think one of the reasons it got passed is their colleagues are so sick of hearing them talk about it all the time. And then on the left is Representative Doris Matsui, who's from Sacramento. She's on the Energy and Commerce Committee in the House. And on the far right is Leonard Lance from New Jersey, also on the Energy and Commerce Committee. Now, certainly for the two women on the left, Doris Matsui has a sister who has schizophrenia, so this is a very personal thing for her. She's witnessed what, kind of the trajectory, kind of the life that her sister has had, and how improved services could impact that. Senator Stabenow is a social worker, but she tells a great story of being in a graduate class, in a lecture at Michigan State University, which I won't hold that against her, and a person talking about this new thing called manic depression and a medication that was being introduced to treat manic depression. And as she listened to that description, she said, this little light bulb went off and said, that's my dad. And so she, her father had multiple hospitalizations when she grew up. She never really understood what was going on. So for her also that this is very personal. And I would imagine, the other two guys don't talk about that, I would imagine that there's some connection there as well. So it's interesting, even in politics, a lot of this stuff is also based on personal experience. So we had bipartisan legislation introduced, and then what ended up happening was that a version of this bill was included in the Protecting Access to Medicare Act, which was passed on March 31st, signed by the President on April 1st. So this went from being a mandatory Medicaid program to being a Medicaid state demonstration program. Can anybody, I'm going to look around the room, and people on the phone too can type in your answer. Can anybody guess why it went from being a mandatory 50-state program to an optional 8-state 2-year program? Kevin, everyone is, no one's talking, but everyone is doing the money sign, the universal money sign. That's exactly how we got where we were, right? So the bill, so we had to scale, not we, our sponsors had to scale the bill to the provision to be kind of proportionate to the other things that were in the legislation and within the overall amount of money that Congress had to pay for it. And I should say to the folks on the phone, there is a way for you to send questions by typing them in, and we'll take questions at any time. So, feel free to, if something stirs you, to weigh in. We're happy to do that. So again, what we're trying to do here is to create national standards around what does it mean to provide behavioral health services, and the structure that is included in the statute creates a thing called Certified Community Behavioral Health Clinics. Now, I'm looking around the room. Nobody here is young enough to remember when there was a federal community mental health center program. But there was such a thing where the federal government actually paid for the construction of a network of community mental health centers across the country, had standards for the types of services that they would provide, and then had a lot of oversight. And that program existed from 1963 until 1981. So sometimes I refer to this idea as our back to the future idea, which is can we go back to having some kind of federal structure around behavioral health services? For me also, I think about, I remember in 1999 going to a meeting at the Substance Abuse and Mental Health Services Administration. I had this small project. I was working with a national association that represented mental health planning councils. And going to a meeting with this guy named Mike English, who ran a program at SAMHSA that was all about identifying evidence-based practices. And he wanted to work with planning councils because he said, we've spent all this money demonstrating that certain interventions improve outcomes for people with serious mental illness, that they have an evidence base, and we can't get anybody to adopt them. Can you help us? And he kind of thought that maybe citizen advocacy through the Planning Council could propel adoption of evidence-based practice. And what we've learned over the years is that many of these practices are expensive. Sometimes they don't align with existing funding models, and therefore they're very unevenly available across the country, sometimes even within a state, right? That they're very, that one county might subsidize something where another county doesn't, or there's a priority, priority issue in one place so that a particular type of service is available. And our kind of silly idea is, shouldn't people with serious mental illness have access to evidence-based practices no matter where they live? Shouldn't there be a way? So this not only then creates the standards, but also then tries to create a funding system to make that available. So that was kind of the idea here, was if we understand that one of the barriers is actually paying for this, the statute calls for the development of a prospective payment system that would be adequate, that would be aligned with the standards in the statute that kind of required services, so that those could actually be available. So this will be ultimately be an 8-state, 2-year demonstration program. And states would first have to apply for a planning grant, and we'll walk through the timeline on this. The cool thing about the planning grant is that it gives states an opportunity to interact with stakeholders, with consumers and families and providers and others, CCOs, other interested parties, to kind of work through that process. There's nothing in the statute that obligates a state that receives a planning grant from having to apply to be part of the demonstration, but the opposite is true as well, that only states that receive planning grants would be eligible to apply and participate in the demo. So, part of, I have a really active social life, so I had fun reading your Oregon Health Authority Behavioral Health Strategic Plan more than once. And what struck me is that the goals that you've articulated, that you heard from your communities about the needs in terms of crisis response, a continuum of care, supporting integration, those things are also very aligned with a lot of the criteria that exist in the statute, and we'll talk about that more as we go forward. So at the very least, I think you would have an opportunity through the federal planning grant process to even make progress even on things you've already identified. So I think there's a lot of synergy. And then to try to make this palatable for states who want to participate, the federal government is also making additional FMAP or additional Medicaid money available. And the way this will work is slightly more complicated than we would have liked, but it is what it is. That for your Medicaid expansion population, they'll continue to get whatever the match rate is. So right now it's 100%. It'll phase down. So they'll get whatever that enhanced match is. And then for traditional Medicaid populations, your state will get a slight increase in FMAP. The rate will be increased to what your CHIP rate is. So that goes, for Oregon, it's about an extra 10 cents. So you'll go to about 75 cents federal money, 25 cents federal state money for every dollar that you spend in Medicaid. So that's a 10-cent increase. All right, does that all make sense? Then real fun, we'll get into the details. All right, so the statute laid out a series of deadlines for implementation. And maybe I'll just digress for a second that this bill was passed, as I said, March 31st last year, and then very soon after this, the National Council had our annual meeting. And one of the speakers at our annual meeting came from the Centers for Medicare and Medicaid Services, and it was her office that would be in charge of implementing this. And she got up and she said, wow, this timeline is really aggressive. It's going to be really difficult for us to meet all of these commitments. The next day, I'm with a group of people from Michigan, and we're in a room. For those of you on the phone, we're in a room about the same size as the one we're sitting in now. And Senator Stabenow comes in, and who was one of the sponsors of this bill, and she said, that timeline is too slow. They've got to work faster, and it's my commitment to make them work faster. And guess who's winning? So CMS and SAMHSA have said that they will be accelerating this timeline and trying to get the certification criteria first published in the Federal Register for public comment in February. They're anticipating that the period for public comment will be very short, probably about 2 weeks. And then they're hoping to make available the RFP to states in May rather than September. So there'd be the final criteria and the RFP to states to apply for a planning grant. The statute included an appropriated $25 million for state planning grants. There's no limit in the statute as to the number of states that could be awarded planning grants, and I don't have any idea how CMS and SAMHSA will approach that, if they'll put any kind of numerical limit. So the first opportunity, so the planning grants would be available then, and then the award date would be January 1st, 2016. And I have subsequent slides that go into more details, but I'm happy to answer any questions. And the target date for the 2-year demonstration to begin, or for the states to be selected, is September 1, 2017. So hopefully there's, enough, try to allow enough time for the planning process to actually work, and we'll talk a little bit about what that is. So the idea here is that that states would go about certifying these community behavioral health clinics as meeting the standards articulated in the statute, and there was we did a lot of work with the National Association of Community Health Centers to try to align standards for this program with the standards that exist for FQHCs, because they also receive a prospective payment under Medicaid. So the participation is limited to nonprofit organizations or local government entities. So that is one of the limitations. So then I want to talk a little bit about the statute. Then goes into detail about what are the required services. So if you look back, it says who's eligible to become a certified community behavioral health clinic. It says a nonprofit organization or local government entity that meets the criteria, and then the statute goes into some detail about what are the required services. And so the criteria are really kind of fall into a couple of buckets. They fall into buckets related to required services, coordination of care requirements, staffing requirements, and quality reporting. So those are the big 4 buckets of criteria for an organization. And on the scope of services, there's 2 things to keep in mind. One is if your state does not currently cover this service, it doesn't seem fair that you would be held that it would be get a demerit for you not being able to provide it. So we're going to see how this gets interpreted, but the statute says something like, to the extent the service is covered by your state Medicaid plan, you're required to provide it. Secondly, the statute also says that a certified community behavioral health clinic either has to provide these services directly or contract with another entity to do it. What we don't know is what the standard is going to be. How much of the services do they have to do directly versus how many do they contract, how much do they contract out? You know, I would say as the National Council, we did suggest that there be a threshold. I think our threshold was 65% have to be done directly by the organization. But looking at different comments that were submitted, people were all over the place as to what that number would be, and I don't know what SAMHSA will do. And maybe let's take a step back. So there are 3 federal agencies working on implementing this. So SAMHSA, the Substance Abuse and Mental Health Services Administration, is taking the lead on developing the certification criteria. The Centers for Medicare and Medicaid Services are taking the lead on developing the prospective payment system. And then a third agency within HHS, the Assistant Secretary for Planning and Evaluation, is taking the lead on designing the evaluation component of this. So there's 3 agencies. Obviously, those 3 agencies have to be working very closely together because you need payment policy to be consistent with the certification criteria, and then all of that should feed into the evaluation. God willing, that's what will happen. So all that, and then the statute then talks about what are the required services, and I'm showing you the exact detail that's from the statute, right? So there's not, there's always this tension: how much do you put in statute versus how much gets worked out in regulations? Any of you who have read the Affordable Care Act would realize that the most common phrase in those 1,100 pages of statutory language is the secretary shall, right? So that they try to leave a lot of discretion to the secretary, and I think the same thing is happening here. So crisis mental health services, and the statute actually says, including 24-hour mobile crisis team, emergency crisis intervention services, and crisis stabilization. So that's the complete requirement. Now, I have to say, politically, we thought this was the right thing to do, right? This is the kind of services that individuals, families, communities want to have access to when people are having an exacerbation of their mental illness. Having that kind of response is very important. You know, politically, throughout this process, the inclusion of this criteria meant that every time we did an event on Capitol Hill, there were 2 or 3 sheriffs there who were like so grateful that they would have access to these kinds of services in their communities, because they hate the idea of putting people in squad cars and handcuffs who are actively psychotic and driving them hours and hours and hours to go somewhere. They loved this idea. So just something for you all to think about politically too, as you're going forward, trying to have some alignment with local law enforcement. So way back when, in 2007, when this idea was first constructed, what we did is we sat down and all right. So I talked about the Community Mental Health Centers program that used to exist in the federal government. The last time that program was changed was in 1979, the Community Mental Health Systems Act. That was the last piece of legislation that Jimmy Carter signed before he left office. So we took that definition, we looked at that, we did a side-by-side then with the definition for FQHCs, and then we thought about what's changed since then, and what would make more sense. And so, so some of these things actually have precedent in federal law. That was kind of fun. So screening, assessment, and diagnosis, person-centered treatment planning, outpatient mental health, and substance use services. And there's 2 things I want to say there. If you look at this whole scope of services, we would assume that they would equally apply to people who have mental health disorders and substance use disorders. So there's no reason why they couldn't apply to both. We have certainly been very vocal in our comments both to CMS and SAMHSA on that regard, as have our legislative sponsors, that everybody is of that opinion, that this is not just exclusively for people with substance use disorders. So the statute also calls for outpatient clinical primary care screening and monitoring of key health indicators and health risk. So I think the idea here is we know about the high rates of chronic health conditions amongst populations who have mental health and substance use disorders. I think there's a growing movement around the country for behavioral health organizations to be paying more attention to primary care needs, and the idea here is that organizations would be screening for key health indicators. Now, the scope of services at one point had very specific things in there. Those got taken out. We'll have to see what's included in the regulatory process. Targeted case management, psychiatric rehab. Also, psychiatric rehab at one point had very specific details, assertive community treatment, supported education, supported employment. We've been very vocal in our comments that we'd like to see them get to that level of specificity because, again, those are some of the services that are the hardest for states to find a way to pay for in their Medicaid program. So we thought the ability to do that under a PPS system would be important. Family and peer support. So again, we think that applies both to mental health and substance use. And then Senator Stabenow actually came up with this one on her own, this intensive community-based mental health care for members of the armed forces and veterans, particularly those members and veterans located in rural areas. So the idea here is we know that there's a lot of National Guard and Reserve components being, having served in Operation Enduring Freedom and Iraqi freedom. So that the idea here is that to make sure they have access, and you'll see in the coordination of care requirements that pops up as well. So any questions about scope of services, either on the
Just another question. Any definition on targeted case management?
Right. So again, the statute doesn't have definitions for any of these things. The definitions will be coming out in the draft regs that we hope to see in just a few weeks from SAMHSA. That will be kind of our first indication of what kind of what they're thinking. I would just say the National Council, since this is a 2-year, 8-state demonstration program, our recommendation is that they defer a lot to existing state standards related to these services rather than trying to create a whole new kind of regulatory regime. Just given the timing for implementation, we didn't think that that would be a realistic way to go. Now, I would be the first one to admit if this was a mandatory 50-state program, I might have a different idea. But since it's not, we argued for a little more flexibility.
Chuck, to repeat the question.
Oh yeah.
So does primary care screening/monitoring need to happen on site, or can it be coordinated?
So the question is, does the primary care screening have to happen on site, or can it be coordinated? Again, for all of these services, what the statute says is that they either have to be provided directly or through contract. So I would imagine that just like any of the others, that an entity could contract with a specialty substance use organization to provide the outpatient substance use care if they need to, or in some states there are particular entities that run crisis response or do targeted case management, et cetera, that would fall be the same way that service could be contracted out. Kevin?
I kind of heard that differently. One of the hiccups is you have to exceed legislation requirement services to deliver.
Oh.
In clinic.
Right. Right. So
maybe need.
Yeah. So Kevin is raising a question about for federally qualified health centers, their payment is tied to services that are provided within the 4 walls of that clinic. And certainly we've weighed in our comments to CMS on the payment, on the payment system, that again, the payment system needs to be consistent with the required services. And if you look at some of these services like psychiatric rehab, targeted case management, et cetera, those frequently happen outside the 4 walls of the clinic, that there's no reason why payment needs to be consistent with that. We also, in our comments, talked also about telehealth, remote monitoring, other uses of technology to deliver these services, that we also feel that those should be eligible for reimbursement, which is not necessarily the case on the FQHC side.
So I'm just curious about the language. The primary care is just limited to that.
It's just limited to that. So the question was, it says primary care screening and monitoring. So is this the provision of primary care or not? And the answer is, for political reasons, it's screening and monitoring of key health indicators, not the delivery of primary care. There were some other organizations that had some opinions about this list. You could assume that. You could assume that. I didn't say that. Right, so I think the first version of the required services said something slightly different.
See you later.
Well, no, but no. So that gets into then, kind of the requirements of that. These are not entities living in a bubble. That there's a whole section in here that, beyond, in addition to your scope of service requirements, are also care coordination requirements. And I think that's where this then gets addressed. Is that certified community clinics will be required to coordinate care across settings and providers to ensure seamless transitions for patients across the full spectrum of health services, including acute, chronic, and behavioral health needs. Again, the care coordination requirement shall include partnerships or formal contracts with the following. And then there's a whole list then of entities that certified community behavioral health clinics are expected to have relationships with, including federally qualified health centers, rural health centers, inpatient psychiatric facilities, substance use detox and residential treatment, other community services, and that's actually a really long list, schools, child welfare agencies, juvenile and criminal justice agencies and facilities, Indian Health Service, state licensed and nationally accredited child placing agencies for therapeutic foster care, and other social and human services. So the idea there is that, again, right, you guys know this better than I do, that patients touch a lot of systems, they have a lot of interactions with other entities, and we want to make sure that care is coordinated, as well as then Department of Veterans Affairs medical centers and outpatient clinics, drop-in centers, as well as inpatient acute care hospitals and hospital outpatient clinics. So the idea is that these organizations would have, that certified clinics would have relationships, would be able to share information and make sure that all the needs of consumers are addressed. And again, then in our comments around the payment system, we thought, well, if this is a requirement, we got to make sure that the payment system actually supports that as well, because a huge problem right now around some care coordination is that if it's not face-to-face with the client, it doesn't get paid for. So obviously, we would hope that that gets addressed in this. If you have an expectation around care coordination, then entities should actually get paid for that. We also have a fantasy, I don't know what CMS will think, that actually being able to pay for the electronic systems that allow for this to happen would probably be a good idea too under the payment rules, but we'll have to see what they think.
On your screen. I'm not sure if that means it's one thing direct one or not.
All right.
If you click right there.
Okay. And then again, not a lot of detail, but there are some requirements around staffing, which I think if you think about their list of required services, the staffing requirements shouldn't surprise anyone, that you'd want a multidisciplinary team, that we'd want to make sure that the facility is licensed or accredited, and that the staff is culturally and linguistically competent. That also seems pretty consistent with things that are identified in your state strategic plan around health equity. So it'll be interesting to see how SAMHSA approaches that from a regulatory perspective, what the requirements are. All right, so in the negotiating process, again, trying to align requirements with those that exist for federally qualified health centers. There were several other things that appear in their statute that are also here. One is that centers have to agree to serve people regardless of their ability to pay. Related to that is that they have to have a sliding scale for payment, and then the crisis management services are available 24 hours a day. Now, we're very much aware that unlike FQHCs, you don't necessarily get federal 330 money to pay for uninsured individuals. So it'll be interesting to see from a regulatory perspective how that gets implemented. I thought it was interesting, the National Association of Medicaid Directors, in their comments around the payment rate, the PPS system, the prospective payment system for this demonstration, actually suggested that the payment system take into account the folks who would show up that are uninsured. So to build that into the prospective payment, which I thought was interesting. That was even further than we went, so I thought that was interesting that they included that. There are some also some requirements around reporting. And all the statute says is encounter data, clinical outcome data, quality data, and such other data as the Secretary requires. Now I have to say, just selfishly, even if we just had encounter data, I would be like over the moon that we can talk about who gets served. We know that that's not far enough, that we need to actually think about are people getting healthier. And that would make me very excited too that we would actually have some data. Now we're suggesting in our comments that CMS and SAMHSA try to align this with existing quality reporting systems. So whether that be health homes or other things that are required, so rather than creating a totally new quality infrastructure that would be a burden for providers and states, that they try to align it as much as they can with existing quality reporting requirements. So again, if we think about where we came, why we, where this idea came from, where are the opportunities that we think exist, it's to try to create a more accessible system that's responsive to consumer and family need, that's consistent across the state. I also saw in your strategic plan that was one of the goals that your state has already identified, that there needed to be a consistent continuum of care. We think providing critical support for local law enforcement, that they've unfortunately in many parts of the country become the de facto mental health system. They don't want to be that. We don't think that's good. So I think this could also be helpful there. Also provides an opportunity to build or enhance community partnerships. I feel like maybe you guys here in this state are probably further along than other states in terms of kind of the way your system has changed has kind of compelled you to do that. I would say as I travel around the country, there are a lot of places where the behavioral health folks don't talk to anybody. They're not connected to anybody. There's not a lot of collaboration happening. So I think that's important. And again, from my perspective, I think this also is a foundation for us to think about the future. If we think about the payment and policy preferences that fairly qualified health centers have, it's built on a lot of things. One of it is they have very good data to talk about what they've been able to achieve, both in terms of quality outcomes as well as savings to the healthcare system. I know some people won't agree with that, but I think they tell a good story about that. And so there are other things that FQHCs get that we think would be good for behavioral health centers to get. So whether that, so that's access to federally subsidized malpractice insurance, discounted pharmacy through the 340B program, et cetera, that those would all be things that we could build on from this infrastructure, as well as other things. I know in a session we had this morning, people talked about the problems in Medicare, that Medicare does not pay for a very broad range of mental health services. And one of the difficulties is when you're talking about changing the Medicare program, that's all federal dollars, so any change, to the Congressional Budget Office is very expensive. So we've already started having fantasies about, could we talk about expanding the continuum of care available in Medicare, but limiting the providers to certified clinics, for example, as a way to make that palatable. So I think this structure also gives us other things that we could do from a federal level to enhance the availability of behavioral health services. And if you think about it the other way as well, one of the problems that we have on the national level is that we don't have any definitions or standards. So when CMS does things like create regulations for the accountable care organizations on the federal level, there's nothing explicitly in there around behavioral health because they don't really have any relationship with any kind of behavioral health entity. There is no, so again, we're hoping that this could help change some of that. All right, so the prospective payment system. So I just want to say a couple things. One, all the statute says is that the federal government would have to create standards for a prospective payment system. It does not say a prospective payment system that looks exactly like what exists for federally qualified health centers. All it says is that you would create a prospective payment system. So we know that CMS has a contractor working on, generating ideas for them, that they're also hoping to publish in February a draft of what they would like the standards to look like. In conversations that I've had, with folks in the federal government, so this is, nothing official, but in conversations, what it seems like is that they're very interested in learning from some of the payment reform that's happening around the country and trying to build on that. And when I hear people describe what they're thinking about, it sounds an awful lot to me like the Oregon alternative payment methodology that exists for FQHCs, that there's a base payment with quality bonuses. They also, I've heard some discussion about differential payment based on kind of severity. Now, I would say that's probably going to be a little bit different because the PPS payment for FQHCs got established in a historical way, and I don't know that we'll have the same structure here for what that base payment will be. I know what we've suggested, what the National Council suggested in our comments to CMS, is that the payment, since it's a 2-year demonstration, that the payment be on a assumed costs. What do we think these services will cost, both directly provided as well as contracted. We did suggest that there be some kind of reconciliation process, and I don't know what what they'll think about that. There are some payment limitations in the statute. So first of all, this is a Medicaid demonstration. So this is only going to pay for services in the Medicaid program. And there are some existing prohibitions in Medicaid statute that were continued here in terms of Medicaid does not generally pay for room and board, does not pay for residential treatment, et cetera. And again, I would say that the National Council did not sit down and come up with this list of exclusions. It was mostly driven actually by the Congressional Budget Office, and that's a whole other discussion. I won't tell you what the Congressional Budget Office's first assumption was about the cost of this program when it was a 50-state mandatory program. I just say that it had a lot of zeros in it, a lot of zeros. So there were some things that had to be done over time. The other concern that the Congressional Budget Office had was under the existing FQHC system, an FQHC can get established and then file a scope of project change, and they open up additional sites in other parts of the state or in their catchment area. And they were worried about the potential cost of that. So it did say that there was a limitation so that when you came in, you could only come in with the number of sites that you had as of April 1, 2014. So if you're a clinic now that's been operating multiple sites, all of those sites would be eligible for the PPS. You just couldn't apply it to future sites. Kevin? Yeah, I think it's just I don't know if the error is in the statute or if the error is in the slide, but yes, it is synonymous. Yeah, it is. So again, since this is a Medicaid program, the person has to be a Medicaid beneficiary in order to receive the enhanced payment. Your state and its application to participate in the demo will indicate which of its existing services are eligible for the prospective payment, and that there needs to be some consistency with the state Medicaid plan. There was so the National Council our first bite at this legislatively was in 2009 during the consideration of the Affordable Care Act. We got just the definition attached to one of the House versions of the Affordable Care Act, and it was just the definition. So what we were worried about is it didn't have any of the payment things with it, so we limited it to just the services that were already in that state's plan. So that's what that is. So we said that there will be a two-stage process. That first, the federal government will be making planning grants available. We understand that this timeline has been accelerated, so that we're actually hoping to see the application process, the RFP, in May of this year, and that those grants would have to be awarded by January 1, 2016. Again, only states that receive the planning grant would be eligible to participate in the demonstration program, and that during the planning grant phase, your state would have to have a process by which they solicit input from stakeholders. That includes patients, providers, and others. They would have to have a process by which they certify clinics, and a process by which they develop a prospective payment system. Again, there's nothing that would say that because you have a planning grant, you have to apply. So, especially given the synergy that I see with your state's strategic plan anyway, this would, give you some additional federal money to actually think about how you can make some progress on those things as well. Also I would imagine under the state planning process, if you think about what's going to be required if your state chooses to pursue the demonstration program, then there are, certain things that it would have to have some agreement on, including the target Medicaid population to be served, the list of participating certified clinics, some kind of attestation by the state that it has certified the clinics as meeting the standards, a description of the particular services to be covered, and the state confirmation that it will provide the PPS rate for those services to the certified clinics. So those would be things that you want to think about. There's also in the statute a waiver of statewide-ness, so this does not have to be available in all parts of the state, so your state could target if it wanted to. There's nothing to say that it has to, but your state could target to particular parts of the state or to particular populations. It would have that flexibility. The statute says just a few things about, kind of preference or selection criteria for participating in the 2-year demo, that states that have the most complete scope of services to individuals eligible for Medicaid would have a preference. So there was a whole other thing happening in last Congress. Congressman Murphy had a bill around assisted outpatient treatment, so he was able to get a provision put into this that to the extent that your state participates in that, that the certified clinics would have to provide services under assisted outpatient treatment. There's nothing in here that says your state has to have an assisted outpatient treatment law. It just says to the extent that your state does, that these clinics would have to apply, they have to participate in that, and that that your state has the potential to expand the availability and quality of mental health services without increasing net federal funding. So again, I think that the idea here is if we can do a better job of providing comprehensive community-based mental health services, that there will be overall savings to the system. And so I think that's what's going to be tested here. So can we improve access? Can it be to a more complete set of services? And can we improve quality? All things I think we would say are important. And then there is an annual report to Congress that says, how is this going? And is the quality and scope better being provided by these centers as compared to other providers? And what's the impact on the federal government in terms of inpatient, emergency, and ambulatory services?
Can FQHCs be CM?
So there's a question asking, can FQHCs be certified clinics? Again, the criteria is, can you provide the required services? That's the criteria. So I know around the country there are organizations that are both community mental health centers and FQHCs. There's nothing in here that says that would say that could not be the case, right? Can you meet the standards is the question. And I would imagine even for organizations that are both, that only certain of their mental health services or behavioral health services are included in their prospective payment. So this would give them the ability to have some enhanced payment for the rest of it. So I know what's happening around the country is that organizations are looking at what their scope of services compared to what's required and making, kind of thinking about where do they need to improve. Some of this is mostly happening, in conjunction with state authorities, that they're kind of thinking about it not just in terms of individual organizations, but also their states. I know a lot of states struggle with crisis response. Some states don't have a really good infrastructure around incorporating peers into or families into the treatment the treatment system, and also then what's the relationship between mental health and substance use. You guys might have, I think your strategic plan lays out kind of some of this, but you might have some other ideas. Again, the question is, getting a planning grant, I think, would be helpful, and then from there you can make a decision about, how you feel about the demo. But I really see no downside to getting a planning grant. So I think we've all had enough PowerPoints in our lives. So let's stop there, and then we have opportunity for discussion, both in terms of reactions, questions. I would say that I'm fairly a bit handicapped. We know what the statute says. We don't know what the regulations are going to look like. We'll see that very soon. We'll see, both in terms of how much will they defer to existing state standards versus how much will be new, and also what CMS's approach to the prospective payment will be. But I'd say, who would have thunk in this time of all we hear about is that the federal government doesn't have new money, we're not going to invest in new things, that Congress is able to say, we think it's important, improving access to care is important enough that we're going to invest over $1 billion, over $1 billion. And just to be clear, that $1.1 billion is just the Congressional Budget Office estimate. It's not a ceiling, right? It's just what the Congressional Budget Office assumed it would cost. You know, there is no ceiling. That doesn't translate into a cap. So for those on the phone, if you feel free to send in questions, and then looking around the table here at my colleagues, my friend.
I have a question regarding the improved, under the Secretary showed you a preference to improve availability of access to and participation in required PCV-HC services and assisted outpatient treatment in the state. I'm hoping for some assurance that in no way would those be opting out of assisted outpatient treatment called by many of my peers forced community treatment.
Yeah.
That in no way opting out of that would lessen the state's opportunity.
Yeah, my understanding is to the extent that your state has, it would be to the extent that your state has an outpatient commitment law that there be some expectation that clinics participate, not that it would be a demerit against them.
Okay, so, okay, all right.
But again, I think we'll need to wait to see, you know, what the SAMHSA standards, what the SAMHSA standards say.
I have a question about the process of payment and understanding we don't want the net cost to increase. I get that part. And so I assume that with the primary care services and the specialty mental health and addiction services, that all gets rolled into the CPS payment. How is the grant money supposed to be used? Is that supposed to be part of the CPS payment?
I'm sorry, I'm not sure what you mean when you say the grant money.
The startup money, whatever.
Planning grant money.
Well, the planning grant, so the planning grant money is to your state for it to prepare, you know, kind of to do the certification process, for it to develop its prospective payment. That planning grant money does not go directly to the clinics, to the services. That's more a, you know, kind of, as we thought about the, you know, how to make all of this work, there were 3 pots of money that, you know, there was the mandatory Medicaid spending for the PPS, you know, the enhanced FMAP. There was the planning grant money to states so that, you know, states actually had some ability to hire, you know, to participate. And then it also, the statute also included $2 million to the federal agencies for them to have some money as well. So
can part of that planning grant be used to support the agencies in getting certified?
I have no idea.
And
That's
if you
a
could
cost.
Yeah.
repeat questions that are being spoken
Okay.
in the room.
So part of the question was, you know, there's some very specific questions about the planning grants and their intended use. You know, my impression is that the planning grant is money to the state for it to have some bandwidth to do all of the things it needs to do. Think about the populations it wants to serve, certify clinics, as well as develop a prospective payment system. Leslie Ford asked the question, well, could some of that money go to providers to help them? You know, again, we don't know. I mean, that will be in the application, but that, you know, we certainly can put that on the back, you know, so you ask that question. So there's a question from Linda, from someone named Linda about kind of the 24-hour crisis center. But I have to admit, I don't understand the question. So I don't know if is the question. I'm wondering if the question is, since it's not in an existing service in Oregon, could that be paid for? Is that what she's asking?
I can unmute her if she would
Yeah.
like to.
So Linda, we're going to unmute you.
All right, you're unmuted, Linda. Are you there, Linda?
Linda Pritchett asked a question about crisis services. Okay. Well, Linda, you're unmuted if you want to ask your question, or you can type the question again, either here or to me directly. All right, get her again. Kevin.
So just to follow up on Leslie's question, because I don't think the state providers as much as it's how the planning happens. And to me, there's really three layers of planning. There's the state layer, there's the provider layer, conduit that Medicaid money out to them. And so to the extent, two-part question. To the extent that the state can demonstrate to utilize all physical measures of classes on policy on exercise or improve bottom-up exercise. And to the extent that more rural parts of the state can demonstrate how to the chair services, telecommunications, other increasing infrastructure to actually provide state life. Those two together. But I don't know if that was
So Kevin is asking a question which really is more like a recommendation. So what I
Before you repeat it, I'd like to just offer a friendly addition to you scoped out 3 levels. I would add a 4th, I don't know if it's a level, but a 4th thing, and that's the local mental health authority, who in Oregon largely manages for the dispatcher or whatever of crisis services. So that's going to become a factor. And now,
and I was kind of lumping that into that 3rd level, not only the authority, but also the constituents.
So the questions from Kevin and Maggie in the room really are about the, in the planning process that there are obviously multiple levels of the planning, right? It's kind of the state, providers, and then intermediaries, whether those be local mental health authorities or CCOs. And the question, which I can't answer, but I think is a good one, is how will the guidance be structured on the use of those planning grant dollars and in order both to facilitate input. I mean, I think the input part is very clear, but then also I don't know if they're contemplating any of that money being used, by those systems. But so I think those are recommendations that we can certainly share with the federal agencies. So more than a question that I can answer, I think it's something that we could, it's a recommendation that we could work on with you to forward to the federal agencies.
Can you clarify what needs to be?
So there's a question about can I clarify what needs to be in place in order to apply for a planning grant? So the again, we have no idea what the feds are going to ask for from the states, in order to award a planning grant. We think that we'll see the RFA fairly soon. Here's my hunch, right? They want states to do this. I can't imagine that they're going to make a planning grant very complicated to get. I think, if you think about what's required under it, I'm sure they're going to have some standards for stakeholder involvement, some sense from the state, if they have any preliminary sense about, what they're thinking, both in terms of target population. But I doubt actually even they'll go that far. I think it'll be, my hunch is that it'll be pretty straightforward because I think they want to encourage a lot of states to participate because it's only the states that get planning grants that would then be eligible to participate in the demo. And I think everybody probably has an interest in making that number fairly large. But without seeing guidance, it's hard. So I said that's the tension that we're in, is that what I can tell you is what's in the statute. I can't tell you yet what what the agencies are thinking.
Question starts right here.
So there's a question from my old friend David Pollack about the medical directors and kind of expectations around psychiatrists as medical directors and also their functions. And you know, I think that again, nothing about that is spelled out in the statute. Certainly, the American Psychiatric Association has been very vocal about their intention of centers having a psychiatric a medical director that is a psychiatrist. And then in terms of the individual functions of that medical director, again, not spelled out anywhere in the statute. Again, if I think back to, what was some of the reasons that the National Council began thinking about this, right? If I travel around the country and I talk to our members, I talk to community mental health programs around the country. Maybe it's different here in Oregon, but I don't know many that can bill enough money to actually cover the cost of their psychiatrist. That for most centers, your psychiatrist is a loss leader. I don't know in what other part of medicine is your physician your loss leader, but that is the unfortunate position we're in now. Or that members can't afford to hire psychologists or clinical social workers or other types of professionals. And the idea here is that hopefully the idea behind the prospective payment system is to make it possible for people to hire whatever staff they think is necessary to provide the services and actually get paid enough to actually cover that cost. So that was kind of our very simplistic thinking behind this. Was, wouldn't it be great if you actually got paid to hire clinical people? So the question is, there's another follow-up question around the Satellite Offices Act for April 2014. If the ancillary office is developed to meet the scope of services for the grant, could services be covered? Again, I think I can't answer that. That's going to be in the guidance. How are they going to interpret that provision around satellite offices? And also, how are they going to deal with this issue of if services aren't covered in your state plan, but as part of this process, your state wants to add that, is that going to be okay? So I think those are technical questions that unfortunately, I don't know the answer to, but those are good questions. So the follow-up question saying, would Oregon have to have state standards already established to apply for the planning grant? Again, I don't know how. I don't know how the federal agencies are going to approach that question. How directive they're going to be versus what are they going to allow? How are they going to defer to existing state standards? But you raise a good question. What if your state doesn't have a standard? I think we'll know once we see the Federal Register notices about how they'll approach that. You guys are asking good questions. There's just things that, without not being the person writing the regulations, it's hard to answer.
I'm asking the question to check to not be confused. I'm thinking of Pam and Kevin. So a lot of yeah, I've been wearing him out. So it seems to me that really I want to know something correctly. It seems to me that the state's role, in addition to having to do the certification for whatever agencies participate in this, the other huge amount of work would be to establish what the PCS is and how that would supplant the other streams of funding that person otherwise would be paid for. Is that really where the bulk of the work is? Am I thinking about this the right way?
And is that at the state level, or is that being developed at the federal level?
Well, it is being developed at the federal level, but we would also, we discussed this morning about how, using essentially a consultant, a company, there was one name that was out on the table, the same one that the National Council is using that we're familiar with to actually help us develop that. It's be a very complex actuarial financial process, and but even with that, I think we know, even when we get that kind of expert guidance, it will be a huge lift for Medicaid.
I've always got two questions around the state process, the timing of this. being so challenging, how would it work with the state legislature? I'm thinking we're in a biennium. So that next year, I would state awards or how do we? So how does it interact with the legislature? Put it that way.
Karen's going to answer that question.
And I have a second question.
Let's repeat your question, and then Karen Wheeler is going to answer the question.
Well, the timing of the federal legislation, timeline now, how does it fit within the legislative cycle? And the second thing is on prospective payment, and because that seems what this is about, is trying to establish a justification for prospective payment. And it seems to be following FQAC, an example. But there are rules within FQAC for payments that we have found in the FQAC don't create a great deal of advantage on the mental health side, like paying for only one service for the same diagnosis, not paying for case management. Those things, just case management just gets deducted. So I think those are important things that if they're going to follow the FQAC rules, we're going to look at issues like that, but the legislative side.
Well, let me just say that it's very clear that this is not following FQHC PPS. There's nothing in the statute that says that it's based that way, and certainly in discussing with the federal agencies, that's not their intent. So I'll just say that. And also to the extent that they realize that the payment method has to be consistent with the required services. So if you're going to require people to do these things, then the PPS has to cover them.
So the question that Ed asked about the federal timeline versus the Oregon legislature timeline, I think you're asking just about when we apply for a grant, we have to get approval and how that would work. So there's a process through Ways and Means where we can ask for a retroactive approval once the standards or the guidelines come out on the grant. I think we're kind of ahead of the game here, so we can get ready and have everything ready to not miss any deadlines and go up in front of Ways and Means and ask for permission to apply for the grant.
So I'd like to rise to the debate and ask a question about perspective payment technology, because I think this would actually be a real time with the CCO development. We're dealing with the CMS for two things in mind. We have a global budget approved by leadership, and then somewhere down in the lower part of the CMS, the actuary is saying absolutely have to have actual accounts to create that. It occurs to me that relationships really don't have and a lot of what we're talking about with CCPC is establishing relationships with clients and also with partners and dealing with folks in terms of health and all this how we're driving costs. So Oregon may be very well positioned to come up with a methodology cuts across both physical health and behavioral health, but also helps us demonstrate how we can enhance Medicaid services with non-Medicaid dollars, or how we can possibly use Medicaid dollars to make them more flexible and code.
Is that a question to me or to Pam? I think it's more of a question to Pam.
It is the biggest issue on the radar right now, which is our 2015 rate. Global budget feels like it's out the door, and if we continue down that path and alternative payment methodology is going to be out the door because that's the counterfeit we pay for.
So this is Pam Martin, and I'm responding to, I think, some general comments by Kevin about, let's see if I understand the essence of it, is how do we create a system where we have global flexible funding around the person no matter what their need is, if it's behavioral health or if it's medical, and how we address the triple aim in that way. And that's as problematic. Is that?
He also, and there's another part of this about the actuarial soundness requirements within Medicaid. And those, I mean, the problem is that that's the statutory requirement going back to the Balanced Budget Act of '97. And unless that provision is taken out, then the CMS has a problem. And if we remember, to remember why that got put in, because people were afraid managed care companies were not spending enough money on care. So that's how that provision got put in. So I think part of CMS's challenge is that they've got that existing statutory requirement that rates be actuarially sound. And I know they're actually, CMS has a whole rulemaking process going on right now around actuarial soundness. So
I think it's kind of a big thing for that.
yeah.
But Pam is right. The real question is, how do we start paying for outcomes rather than paying for
So I wanted to respond by just sharing with the group here and people on the phone that before this meeting, which is made up of the staff, a little bit by the Transformation Center, but mostly by Addictions and Mental Health, that before this meeting, we had a meeting with the Oregon Health Authority leadership, including the Director of Public Health, the Chief Medical Officer, the Chief Medical Officer of the Transformation Center people, and MAP, and so that there's a true understanding that just the way SAMHSA and CMS and other areas have to work together at the federal level, that the same kind of configuration has to be here in Oregon, where a tremendous amount of the work has to be done by Medicaid with outside actuarial consultation, in consultation with coordinated care organizations who are doing the heavy lift on healthcare transformation, and that some of the regulatory criteria building, some of those things probably sit with Addictions and Mental Health, but Public Health has a role, the Transformation Center has a role, and that's just within us. After this, if there's general agreement by all parties, providers, CCOs, community mental health organizations, everybody, that we go forward, then we have to reach out to the rest of our partners, DHS, the criminal justice system, education, consumers, all of our advisory boards. So, so this is something where we're trying to start early because there's so many moving parts to this. But so far, in terms of what we've heard from Chuck and what we can read between the lines, it does seem as if a lot of the work is already being done in Oregon, and so that we have, you know, we probably have a really good opportunity here to take some of the things that are happening, like behavioral health home standards, and make sure that they're aligned not only with PCPCHs, but with this new effort, and then, you know, one and done. So we have and also the efforts that have been made around the budgeting for the CCOs seems like a perfect opportunity. But I didn't want the impression to remain, or to be created, that this was, that we don't have Medicaid and health analytics, and everybody else here has to be all in. And I've received a number of emails from people saying, hey, this is a great idea, let's go forward. But having Chuck here and having some follow-up sessions and follow-up webinars that we'll make sure everybody knows about when the actual standards come out, and then doing whatever kind of internal and external polling we need to make sure that everybody is feeling a high comfort level with this project, which literally does involve everybody. Yeah. I'm sorry, Chuck?
No.
Okay.
Okay.
Well, thank you. That was great. And I'm pleased to hear about the receptivity around it. It seems to me that this is a little bit tagging on to what Kevin said, that at least some substudies have to be done anyway, and that getting a state grant to help us do the work we have to do anyway is not a bad idea. I just want to add to the list that you created of things that are already going on. That our organization, Cascadia, is one of the 100 or so grantees, the SAMHSA grantees for the immigration grant, And as you know, we've got all this stuff and loads more, and we're doing the outcomes thing, and so it seems like this beautiful start to all of this with a brick wall, and it's really a brick wall. And that is, you know, nobody is, we now think we can figure out what it actually costs to deliver this care for the people in this grant project, but nobody is asking us how much does it cost, because no one person cares except us. So, you know, these people care about that part, these people care about that part, and these people care about that part. So it seems to us that for sustainability, for any of that kind of effort, we've got to do this work, at least some subset of this work. So I just wanted to add that to your list of how we're already nicely positioned.
Thanks, Maggie. Yeah, absolutely. We should always remember how far so many providers have come already.
So there's a question that I got on my email that says, the question is for Pam Martin. Hopefully Oregon will consider seeking a planning grant, and if so, how can local nonprofits like Bridgeway support the state's efforts?
Oh, that's a great question. I don't know yet. I don't know yet, but we hope to find out in February, and this is this is the groundwork for that. We've already just had, again, just based on the discussions already, we've had a preliminary discussion with Mike Levacek, who's our new director of the Office of Consumer Activities, to think about where he would get look for opportunities for consumer input as well. And so we've got a lot of places to look, and thanks for the folks from Bridgeway. And
well, I'm of the same frame of mind. For me, I don't need to be dismissive to anybody, but as long as it is before the waiver, the planning grant is really a no-brainer. That decision. However, I think that there's probably somebody deep inside of the health authority who's saying, oh my God, I hope it's no good, because it's just a cascade, a tsunami of work that's coming their way. So I think that ought to really be passing the hat for expertise and committing time to be part of the planning and implementation team at all three levels as I discussed earlier. Whether it's like PCO, or OB, or providers, who say 8 or 10 FTE or 20 FTE to both develop the planning grant and develop the network, exactly what Pam talked about. Because it's just as important. The sheriff out in Gillum County, the sheriff, and it's really important to get the state license issue out of the way quicker rather than later. So I'm looking for more of that rural paranoia that feels like if it's pared down at all, so it's not a question, it's more of a call to arms. I've got 2 FTEs.
Do I hear 3? No. No.
I heard 1 from Bridgeway.
Yeah. So again, just for the folks on the phone, this is Kevin Campbell, again making a comment, that wanting to seek commitment both about the planning grant, but also more importantly the planning process, and also indicating that the idea of having a network across the 3 levels that he talked about earlier, the state, providers, and intermediaries, whether those be CCOs or local mental health authorities, kind of committing to that process, and he actually put some FTEs on the table to be part of that process.
And one of them knows who she is.
I'll leave that with you.
well,
there are no more questions online, except for David Pollack. And David, why don't you call me we can talk about your question?
Well, could we talk a little bit about David's question? Because I think that it really calls out a bigger issue. We have a vision of CCO world, everybody is being enrolled in person-centered primary care at home. So you're going to have family practice, self-driving, whole person care. When you move into both PCPCH and CCPHC, is the vision that people's overall primary care would still be addressed in person-centered primary care at home. And then, but also, that's where the basic wellness is. The CCPHC is one of the basic products to most wellness activities to be monitored. You're more likely to have interaction there rather than at the medical. But at the end of the day, the role of the psychiatrist in the overall treatment plan, whether it's the population that gets specialty care for their multiple chronic conditions or health challenges, who's driving care and what the regulations talk about the interaction with home is really pretty important.
So David, Kevin's supporting you here, saying that and in a quite elegant way, talking about the interaction between primary care and behavioral health, or in this case, certified clinics, and kind of what's the role of psychiatry in that. And
allow both of them to operate at the top of the line.
Absolutely. And again, that's not something that was envisioned in the statute. And be curious, Kevin, how much detail is included in the Federal Register notice about this or not. And also, I'm making a note that maybe we need to have some specific follow-up, with folks here in Oregon about what kind of comments do we want to make back. Just on a total aside, I'm working with another Senate office right now on some language for Medicare around paying for collaborative care. So it's the same kind of thing. How do we actually make it possible in Medicare for the care management and the psychiatric consultation to be paid for, that that kind of approach could actually be sustainable within Medicare. I think it makes sense to think about that also in this context. So that's not anything we've commented on so far, but it does make sense. And
when your CCO charge is 2.4%, 42% of the medical budget, 2.4% of the population. It seems that the psychiatrist embedded within that hotspot team would make a whole lot of sense regardless of what the primary diagnosis is.
Yeah.
Health world guide collaborative effort could make a big impact on multiple.
So Kevin was making, just for folks on the phone, about having a psychiatrist involved in hotspotting teams makes a lot of sense, no matter, regardless of diagnosis.
Well, thank you for the discussion, and this is really just the beginning. This is our kickoff. When the Federal Register information comes out in February, we'll make sure it goes out onto our listserv. We'll make sure that we develop an opportunity for everybody to comment on it, send comments to us, that we will, we'll work with Medicaid, Public Health, Transformation Center, Health Analytics to put all those comments together. We'll also be happy to send out the comments that have already been made by the National Council and also by the National Association of Medicaid Directors, which is a lot of specific information about the payment methodologies. So we'll keep you informed, try to get the information coming. And I would say, based on our discussion so far today and the feedback we've gotten, that it's very likely that Oregon will apply for the planning grant. We just want to make sure that we could also envision ourselves going to the next step, because we're all busy, all very, very busy. We want to make sure that this is consistent with the direction Oregon is going, that it fits into the CCO model, and it fits into our thinking about what we want, what we think will work for people who have these challenges, and what those people think will work for themselves, which is, I think, a piece that we need to add to our planning as quickly as possible.